Hello everyone, my name's Lily, and it's my great pleasure to talk to you today about our project, Trends in Usage and Outcomes in Mechanical Thrombectomy in Acute Ischemic Stroke in the United States from 2014 until 2016. So for a little bit of background, when there is an ischemic stroke or a occlusion of one of the blood vessels leading up to the brain, the major treatment goal is to achieve reperfusion or opening up the clogged artery. And this is crucially important because it's estimated that in this type of stroke, 1.9 million neurons and 14 billion synapses are lost per second prior to treatment. Before 2014, our major treatment option really was something called IV alteplase or IV TPA, and this is a treatment that's given systemically to try and open up that blood clot. There was always interest in mechanical methods of achieving reperfusion, for example, by using suction techniques or using something called a stent retriever. And the basic idea is similar to what we do now for myocardial infarctions, is we go up through the groin and insert a microcatheter with a guide wire, advance it up the major blood vessel in the body, the aorta, and then go up to one of the four vessels that lead up to the brain, and we actually physically make contact with the blood clot and try and remove it mechanically. And so this technique is called mechanical thrombectomy. Here's a patient that underwent mechanical thrombectomy at our center. You can see towards the right side of the page, there is a blocked artery, and anything that's distal to that, we don't have blood flow in. And after the procedure, we see that the blood vessels have come back towards the lateral aspect of the head. And starting in October of 2014, there were 5 large randomized controlled trials, all being announced and published sequentially within the span of about a year, which showed significant benefit to having mechanical thrombectomy in the appropriate patients. So patients with a large artery occlusion that we can reach with a guide catheter. Now, a common outcome that we use in stroke is called the modified Rankin scale. It goes from 0 to 6, with 0 being no disability, 6 being death, and then everything in between in gradients. So a disability score of 1 shows that there's some symptoms, but the patient's able to carry out all normal duties. 2 is their slight disability. They can't carry out all that they could before, but they're able to live independently. So in stroke, typically it's thought that an MRS score of 0 to 2 is a good outcome following stroke. And then 3, 4, and 5 are various states of dependence, with 5 being bedbound. Now, you can see on this picture that the lighter colors are good outcomes, so we want white or light blue, and that overall in the intervention population who got mechanical thrombectomy compared to the control population, there were a lot more people who were able to achieve an MRS of 0 and 2. And if we look below, it doesn't matter if these patients were ineligible for alteplase or received alteplase with their thrombectomy. So this procedure is beneficial for both patients who are able to get TPA and patients who are unable to. And because of all of these trials, the American Heart and Stroke Association drafted a revised focus guideline specifically with regards to acute ischemic stroke and endovascular therapy, recommending it as standard of care in June of 2015. So this is why we chose to look at this period 2014 to 2016, because it's a unique period of transition for several reasons. Not all centers that treat acute ischemic stroke are endovascular capable. This means that when the guidelines came out making endovascular therapy standard of care, there was a lot of systemic reorganization to help facilitate transports to increase access for patients who are seen in more remote centers, and then there are an increase in usage with potentially more procedures done at facilities that are newer to this technique and by less experienced operators. Prior to October of 2014, interestingly, there were 2 trials which failed to show any benefit of mechanical thrombectomy in acute ischemic stroke. And it was thought that these trials were different than the later positive trials because of poor patient selection. So poor selection of patients who would benefit from this procedure. It's interesting to see how outcomes in patients under this procedure may change as this procedure moves from a very strictly controlled trial setting to the more messy clinical setting of real-world day-to-day stroke. So we hope to evaluate temporal trends in the outcome of acute ischemic stroke patients who underwent this procedure, mechanical thrombectomy, after the introduction of practice-changing guidelines, so around that period of 2014 to 2016. We think that the rate of thrombectomy will show a significant increase, and that we hope the mortality of these patients will decrease over this period, and the proportion of patients with good outcome will increase over this period.
Our study design was a retrospective database analysis of publicly available AHRQ Healthcare Utilization Project, also known as HCUP, national inpatient sample from 2014 to 2016. Patients over the age of 18 who were admitted to hospitals receiving mechanical thrombectomy and who carried a diagnosis of acute ischemic stroke from 2014 to 2016 were included in this study. Patients were identified using both ICD-9 and ICD-10 codes for exposure to mechanical thrombectomy and ischemic stroke, and to analyze for trends that occurred over ICD-9 to ICD-10 in Q4 2015. As recommended by HCUP, data were analyzed by discharge quarter using HCUP data element DQTR to examine for discontinuity likely due to that transition from 9 to 10. And we will show you results of that in the next few slides. Our exposure and outcome are listed on this slide. Exposure of interest was mechanical thrombectomy, defined as calendar date of thrombectomy using HCUP data element DQTR. And the outcome of interest, we had two outcomes of interest. First was mortality, whether the patients expired during that hospital admission, and second was discharge to home. Now you will note an asterisk next to this specific outcome. Initially, our team wanted to assess for discharge to long-term care facility to assess whether patients were clinically disabled, but this data element would also include discharge to a rehab facility, which would greatly confound the outcome of interest and not be clinically relevant. So as such, we only assessed the outcome of mortality or discharge to home, and that is a potential limitation of our study to keep in mind throughout this analysis. Study covariates included hospital and patient characteristics, and you will note under the patient characteristics we assessed age, sex, income, insurance status, exposure to IVTPA. And under the hospital characteristics, we wanted to first assess the experience each hospital had performing mechanical thrombectomy, so we did create a new variable using hospital ID, and we called this the number of thrombectomies per year. And we also wanted to assess whether what type of teaching status that hospital had. The next slide shows our directed acyclic graphs, or DAGs, and you will note that we have two DAGs, both for death or discharge to home, and you'll see both patient and hospital characteristics are listed as covariates in this DAG. They are on the causal pathway, and as such, and given the fact that they changed over time, we also assessed calendar time in our study. Our statistical methods are listed on this slide. We first again wanted to look at that discontinuity given the transition from ICD-9 to ICD-10 codes. So first we looked at the rates of acute ischemic stroke and mechanical thrombectomy. We plotted that against time of thrombectomy for visual inspection of discontinuity. Afterwards, we performed regression discontinuity analysis centered around differences between the first 3 quarters of 2015 and the 4th quarter of 2015. And we use this to examine for difference in the intercept of the regression model generated. And then if discontinuity were detected either visually or statistically, we will report the data separately before and after 2015. If they are not, then we will pool the data together and report them from 2014 to 2016. For analysis of trend of usage of and outcomes after thrombectomy, we looked at the proportion of thrombectomy patients who were deceased or discharged to home, and we graphed this across 2014 to 2016 by quartiles to again assess for visual inspection of that discontinuity. We also looked for a logistic model for this analysis. And for the regression model, we looked at the dependent variable being binary 0 as either not deceased or not discharged to home respectively, or 1 deceased or discharged to home respectively. Our independent variables for the first regression was to look at thrombectomy date and calendar time. Again, this is our univariable analysis. Or in our second regression, or a multivariable analysis, we looked at patient characteristics and hospital characteristics along with thrombectomy date and time. The next slide shows our results, or table 1. You'll note the first column is the calendar time by quartile. We also looked at thrombectomy, stroke, TPA transfer, IV thrombolytic use, TPA stroke. And you'll note that between 2015 Q3 and 2015 Q4, that these specific rows were bolded, and specifically 2015 Q4 were the variables that we were concerned with having discontinuity given the ICD-9 to 10 switch. Our next slide shows the graphs of our baseline data. So again, here we were looking for that visual inspection of whether discontinuity occurred. Figure 1 shows thrombectomy coding, and we don't necessarily see a specific shift in Q4 2015. We actually saw that increase prior to that, so we're not necessarily concerned with this discontinuity with this variable. However, when we look at figure 2 with IV TPA coding, we did see a marked difference and change in Q4 2015. So as a result of this, we did code our data separately. So we coded ICD-9 from 2014 and the first 3 quarters of 2015 in one analysis, and we had ICD-10 given the last quarter of 2015 and 2016, and we analyzed those 2 time periods separately.
Table 2A and 2B show the more detailed results from our analysis. As expected, the mean age is in the range of 66-67 years, since strokes are more prevalent among senior citizens, and they would require such procedures more than those in the lower age bracket. There is no significant difference between males and females, and roughly 50% of patients received IV TPA. Also, there's no significant difference between each income category, where quartile 4 being the highest income. In insurance status, however, Medicare takes up more than 50%. It is due to the fact that most senior citizens would utilize their Medicare in treating their strokes. About 27% of patients ended up being serviced at a hospital with less than 4 cases per year, and the number has declined gradually with an exception of quarter 4 in 2015. This suggests that majority of patients access hospitals and care facilities that are experienced in conducting such procedures. Lastly, more and more patients are seeking care in teaching hospitals. And this makes sense, considering the recent nationwide change in practice guidelines of mechanical thrombectomy that would require more experience in-depth training. Table 3 shows results on our outcomes, even though it has been adjusted for survey procedures, but not yet been adjusted for patient hospital characteristics. So you may think of these results as a crude analysis of sort. Next shows the graph for ICD-9 outcomes. There are no significant changes except for quarter 2 in 2015. However, the change occurred but failed to sustain. So at this point, the clinical significance of this change is not yet known. Next one is the graph for ICD-10 outcomes. The graph responds accordingly without any significant outliers. Next up is the adjusted results from ICD-9 and ICD-10 outcomes.
Thanks so much, Jeri. So I'm going to take us through our final results. Looking at the adjusted regression from the ICD-9 period, the first table here shows our analysis for poor outcomes, so patients who died during the same admission that they had their thrombectomy. And we see here that age is a significant predictor, so older age was associated with higher risk or higher odds ratio of dying. We see that sex here was significant, with women having a lower odds of dying. Also, payment status was significant, with payer 4, who was the other payer status, so not Medicare, Medicaid, or private insurance, had a significantly higher odds of dying. And then, last but not least, the number of thrombectomies that the center does. So, unsurprisingly, when a center does more procedures, the patients have a lower odds of mortality. And then, shifting gears a little bit, still staying in the ICD-9 period, so in 2014 to the first 3 quarters of 2015, looking at good outcomes. So patients were able to be discharged home on the same admission that they got their thrombectomy and had their stroke. So this means without requiring long-term care, without requiring a period of intensive inpatient rehab. Now looking here, we see that age again is significant. So with higher age associated with a lower odds of being discharged home. So older patients were less likely to be discharged home. IV TPA was significant, suggesting that patients treated with IV TPA were more likely to be discharged home. Payer 3 was significant, as well as 4. And we see that for patients who had private insurance or people who had other insurance were both more likely to go home. And then finally, the number of thrombectomies was significant. So the more thrombectomies that a hospital did, that patient was more likely to be discharged home. Those are all in keeping with what we expect. But when we take a look at the temporal trend, which we're interested in here, we see that for neither mortality, so the bad outcome, and for discharge home, we see that the temporal trend, which is coded as DQTR all, was not significantly predictive for either of these types of outcomes. Now, looking at the ICD-10 period, again, we see that age is significantly associated with a higher odds of dying, with greater age having a higher odds of dying. We see that the number of thrombectomies was predictive. So if a hospital had fewer thrombectomies, if a hospital did more thrombectomies, then patients had a lower odds of dying, which is as we expect. When we take a look at good outcomes, we see that the significant factors included temporal trends, which we'll talk about more in detail. Again, age, with older patients having lower odds of being discharged home. Female, with female patients having a lower odds of being discharged home. TPA was associated, TPA administration, so patients who got TPA had a higher odds of being discharged home, which is considered a good outcome. And then again, we see payment status 3 and 4, so patients who either had private insurance or had another type of insurance other than Medicare or Medicaid were more likely to be discharged directly home. And here we see that the teaching status of the hospital was significantly associated with the odds of being discharged home, with patients who stayed in teaching hospitals being less likely or having lower odds of being discharged home. And then the number of thrombectomies in the hospital were associated again with the odds of being discharged home, and patients who were admitted to hospitals that did more procedures were more likely to be discharged home. So the temporal trends in this period were very interesting. So looking at mortality, there wasn't really significant associations with temporal trend when we adjust for patient and hospital characteristics. However, when we take a look at the good outcome, so being discharged home, we see that actually as time went on, so as calendar time went on, patients who got this procedure later on in 2016 actually had a lower odds of being discharged home, which is interesting and concerning. So the main findings of our study was that there was a significant discontinuity in the number of patients receiving IV TPA according to ICD-9, ICD-10 codes during that period of switching between the third quarter of 2015 and the fourth quarter of 2015. There's definitely an increasing number of mechanical thrombectomies being done in the United States over the 2014 to 2016 period, as we anticipated. And really concerningly, there appears to be a decreasing trend in the good outcomes seen at least over the ICD-10 data period, especially focusing on the last quarter of 2015 and the entirety of 2016.
This is the first study that examined trends in the use of thrombectomy in acute ischemic stroke patients since the AHA guideline updates, and after the publication of trials support their use as standard of care. This offers a way of assessing impact on real-life outcomes, including any growing pains of reorganizing stroke networks to allow for timely access to a procedure with the ability to offer significant reductions in disability. The NIS offers a large data source which is very amenable to this question, as mechanical thrombectomy is an invasive procedure and ICD coding used to define the patient population is used for remuneration and less likely subject to errors. Many important predictive factors of outcomes after a thrombectomy in AIS cannot be analyzed using the current information. For example, time from symptom onset to thrombectomy, early infarct changes in CT head prior to procedure, patient intracranial to extracranial vessel collateral status, successful recanalization after thrombectomy. All of these cannot be accurately analyzed using the current information. So this makes it difficult to comment on specific reasons leading to any temporal trends seen in the outcomes. Also, it is not possible to identify multiple admissions for the same stroke due to the transfer of care from hospital to hospital. For instance, from a primary stroke center to a tertiary stroke center, or from a tertiary stroke center to a rehab facility. The change from ICD-9 to 10 code occurred over 2015 when a lot of system changes to stroke networks are also being implemented. It would be much better to have a longer period, maybe 3 years of continuous data, to allow for trend analysis. And lastly, our outcome, death as bad outcome versus discharge to home as a good outcome, is relatively crude measure of outcome without capturing subtleties of post-stroke complications.
So in conclusion, we did see that there was significant discontinuity in the number of patients receiving IV-TPA when ICD-9 to ICD-10 switched, and this is concerning given that this code is not something that's usually validated, as it's a procedural code tied to remuneration, which is assumed to have good validity. And there also appears to be a trend favoring fewer good outcomes in ICD-10 data. And this can be due to one of two reasons. One, it could be due to indication creep, where the use of the procedure is being used in patients who may not necessarily fit the inclusion criteria that we're seeing in clinical trials. Or two, it may be due to growing pains of systems reorganizing given the guideline update change in 2015. So it's important to look at outcomes in 2017 to offer further clarification on the real reason here. Further directions, this study is pending submission for consideration for presentation at European Stroke Organization meeting. After feedback, the data will be organized for manuscript, and a similar project using Canadian Discharge Administrative Database is being planned to assess for similar trends in Canada. We'd like to acknowledge our professor, Dr. Ellen McCarthy, and our TA, Geetha Iyer, for their advice throughout this course. We'd also like to thank Dr. Thalia Field of University of British Columbia for her comments on preliminary data as well as suggestions for further directions. And we'd like to thank you for your time and for listening.